byproducts affects the quality of the seal. Siyempre, para sa akin, double-edged sword yung resistance sa marginal leakage ng MTA. It's good because it seals those areas, no? Yung irregular areas doon sa furcation perforation. However, in case retreatment, in case you need to remove it someday, MTA is very difficult to remove because it sets like rock. This material also reduces bacterial migration and it's biocompatible. For example, if you have a furcation perforation repair, tapos may radiolucency sa ilalim nun. This is a case by Dr. Zucker. Yung case niya, nilagyan niya ng MTA yung furcation. Siyempre, kailangan niya ipack ng MTA. Lumabas doon sa periapical tissues kasi may radiolucency nga. Nagpack siya ulit ng second piece ng MTA. Lumabas pa din sa periodontal ligament tissues kasi siyempre niya, nandiyan yung kanyang perforation. Tapos nag-pack siya ng pangatlong MTA. Siyempre, puno na yung radiolucency na MTA dati. Okay lang yun because this is a biocompatible material. Even if part of the MTA cement touches the bone, periodontal ligament tissues, it does not cause any inflammation. It has the least degree of cytotoxicity compared with the other materials that may be used for sealing furcation perforations. And what they were also able to observe that if MTA extrudes into bone or into the periodontal ligament tissues, into the periradicular tissues, eventually the macrophages of the patient will recognize that part, that cement, as not part of oneself, and the macrophages will just eat up those extruded MTA. Kaya nga months after yung recall, ayan, wala na yung extruded MTA. And then months after, you see very good healing at the furcation area. What else? We also see that MTA allows normal healing. It could induce healing in infected tissues. We also see new cementum formation when MTA is used. For ProRoot MTA, so itong example ng setting time and mixing time na to ay yung ProRoot MTA ng Dentsply. The mixing time is 5 minutes and the setting time is about 4 hours. Then yung unang MTA that was introduced in the market. Kaya nung tinatanong nyo ko, alala ko last lecture or 2 lectures ago, yung setting time ng MTA depends on the brand that you are using. So we always have at least 2 or 3 different brands of MTA here in the clinic because we use them for different applications, different cases. So if we have a furcation perforation that we want to repair, we want to seal the furcation perforation at the soonest possible time. So once it's recognized, we can dip the cotton pellet into sodium hypochlorite just to control the bleeding in the area. And once bleeding is controlled, we place mixed MTA over the perforation site. And then the MTA in the perforation site, the MTA that's placed in the perforation site is usually plugged with a moist cotton pellet until the MTA sets. Because it's a hydrophilic material, syempre yung inner part is in contact with the blood, kaya magsiset yun nasa ilalim. Pero yung outer part, mas mabagal magset kung walang moisture. So we place a moist cotton pellet on top of the MTA that we want to set because that will hasten the setting of this material. Once we've plugged the furcation perforation with mineral trioxide aggregate cement, then we continue with shaping and cleaning as if nothing happened. Kasi alam mo, sealed na yung area na yun, then you proceed with the identification of the other canals, you shape and clean the other canals, and then you obturate. Once the tooth is already ready for obturation, we take recall radiographs after a month, after a year, and then 2 years after, just to monitor the healing process. So ito yung isang patient na pagtanggal ng bridge niya. Tapos tinanggal namin yung caries. Sabi ko, sabi ko, ano tong site na to? Pag natatouch ko yan, umaaray yung pasyente. Sabi ko, ano ba yung masakit na yan? So nung verify namin, let it get in contact with the file that's touching this area. Diyan pa lang, babaw pa lang. Tapos maaray na yung pasyente. Sabi ko, merong furcation perforation previously. Previous work sa kanya. So sabi ko dun sa patient, parang may sugat po doon sa loob ng ipin ninyo. we don't elaborate kung kasalanan ng dating dentist or pwede naman kasing carious perforation yan, nung nasira, kaya pala na-perforate sa area niyan. So sabi ko lang, I don't know the real cause because I wasn't there when it happened. But what I know is that we can repair that area. So nilagyan ko lang ng MTA yung area. We can repair that area and observe. So buti na lang, no, nag-respond favorably sa management itong patient na to. We were able to proceed with root canal retreatment after that. So this is a video that I got from the net. Documented cases na perforation repair using MTA. So this patient was referred to Dr. Antonis. Siya rin yung dating nakita natin na mahilig siya mag-document ng cases niya. So naligaw ng landas ang isang file, perforation perforation. So in that area, will be repaired with MTA. So ito yan. Ito yung main canal, ito yung perforation. Diba kamukhang-kamukha naman, di ba? Talagang mapagkakamali. Pero pag ganyan kabilog, isipin mo, ay ano yan, baka burr yung ginamit panghanap ng orifice. We have to resist the temptation of using round burrs to locate the orifices. Let your endodontic explorers look for those orifices. So ito yung kanya, kailangan niya i-repair. So ni-examine niya sa spoon. So kung ako to, unahin ko yung furcation perforation repair bago ako mag-obturate. Kasi ngayon, kailangan niyang linisin mabuti yan. Tapos nako-contaminate yung kanyang kanal. Eh, style niya yan. Wala tayong magagawa. Style niya yan. Kanya-kanyang. So ito naman 2% orhexidine yung ginamit niya sa pag-perforation site. So, di ba nababasa yung ibang canals? So pagkatapos niya linisin mabuti yung perforation site, i-rinse pa siya sterile water, and then the time to dry. Now it's time to dry the perforation. Nilinis pa niya. EDPA pa siya. Series of irrigants na ginagamit. So,
Sa ganyang perforation, Doc.
Ano yan, Doc?
Sa ganyang perforation, Doc, since may contact kasi dun sa soft tissue, may mga chance na nagkakaroon ng allergic reaction kapag ganyan.
Sa so far, walang documented na allergic reaction. Biocompatible material po si MTA.
Hindi dun sa hypochlorite, Doc.
Hypochlorite may iba, Doc. Oo. Kaya mag-iingat.
Diba ni-rinse ng hypochlorite yun bago i-ano?
Iba nagre-react po. Doon kahit ganun ka-konti lang yung contact sa soft tissue, may iba pong patients nagre-react. So mag-iingat mabuti. Problema, wala kasing nakakalinis as clean as yung sodium hypochlorite. So dinidisclose ko sa pasyente. We'll observe po. You have to tell me what you feel once this is irrigated.
Mm-hmm. Thank you po.
Kung sana mangyari sa atin, sa iba na lang. Nakaka-stress kapag ganyan. So babalik ko yung video ng konti. So now, they're showing how MTA should be mixed. So yung MTA powder, hahaluan na. Ito sterile distilled water lang yan, Doc. So kung wala kayo ng distilled water, absolute anong brand nyo, ilagay nyo na sa autoclave para sterile na siya. Yun yung dinadrop ninyo with MTA. Walang recommendation kung ilang drops of liquid sa bawat scoop ng MTA powder. So ito, masyadong basa yung mixture na yan. So kung ako yan, kukuha ko ng sterile na gauze, ididikit ko dyan para makuha yung moisture, ma-absorb yung moisture. Pero siya, ginawa niya, nagdagdag siya ng MTA powder. Siyempre, baka bigay lang sa kanya MTA na yan, baka hindi niya binili, Doc, no? Pandemo na MTA. Kaya yan yung tamang consistency when mixing MTA. Tapos, ito ay Dovgan carrier. Yung available sa atin ay yung mga MTA carriers. Papakita ko mamaya yung photos ng MTA carrier. Tapos, ilo-load nyo na siya dyan sa gun. Pakita niya paano niya ina-assemble. Pero hindi available yan dito sa atin. Yung brand niya. MTA carrier. So, ire-retract niya lang yung syringe. Tapos, insert yan. Ganyan lang. Susunduin niya MTA doon sa tip. So pagkasundo ng MTA, try mo muna mag-extrude ng konting amount so that you get to see if you have the correct consistency of MTA. So ayan, checking. Yan, ang tamang consistency ng MTA para ma-deliver at mapupush nyo siya apically. If the mixture is too wet, hindi nyo siya ma-extrude ng ganyan way. Kung if the mixture is too dry, magsaset siya na nasa loob ng syringe. So dapat ganun yung consistency ng MTA. Kaya may iba't ibang size ng tips ng MTA carrier para mailalagay nyo siya diretso. Yan, yan. The MTA carrier is inserted directly onto the furcation perforation site. MTA is extruded. Tapos, a moistened paper point may be used. Ako mas gusto ko yung handle ng paper point na ginagamit. Yan. Siya hindi, kinakat niya yung paper point, increase tapered, yung matatabang paper point yan, para ma-push niya yung MTA inside the furcation perforation. Ako gusto ko yung handle kasi mas mataba pa siya. And that absorbs also the excess water. So yung MTA, ilalagay pa niya, pupunuin pa niya. Sobra. Dapat tinanggal ng excess agad-agad. Pero napapakita niya sobra, tapos tatanggalin niyo. So pag nakita niyo puno na yung perforation site ng MTA, enough na yun. Tama na. No? Huwag na magdagdag pa na magdagdag. So gamit na naman siya ng paper point, cut paper point to push the MTA into the defect. At saka yun rin yung ginagamit niya na pantanggal ng excess moisture ng MTA. Tatanggalin rin niya yung excess na nilagay niya. Using a small plugger. Yan, para eksakto lang yung MTA doon sa defect. So kung may strip perforation naman tayo, ito yung strip perforation no? Sa inner wall ng ating multi-rooted tooth lumabas. Strip perforation, we need to finish canal shaping and cleaning first. So kapag ginagawa yan, nakakontrol naman ng sodium hypochlorite yung bleeding. Magdadasal ka nga lang na wag allergic yung pasyente mo sa sodium hypochlorite. Then we repair the root perforation and obturate the canal using MTA up to the level where we have the perforation. So kung hanggang dito yung perforation nyo, hanggang buong canal na talaga yung obturation yung MTA. Pero kung dito lang sa middle third or apical third lang yung perforation, then you can proceed with filling using gutta percha, the rest of the canal space. Then, just like in furcation perforation, you take recall radiographs after 6 months, a year, and then after 2 years. Sana ganyan lahat. Sana all na nagre-repair very well yung mga siniseal natin. So this is another video that shows how we manage strip perforation. So ito naman sa paglagay ng post. Kaya ang recommendation ay kung sino yung nag-root canal, sana siya ay nagpe-prepare at least ng post space or better yet, siya ay maglalagay ng post. Kasi alam mo kung paano yung angulation ng canal, paano yung good entry point into the canal. Kasi kapag mali yung angulation ng post space preparation, pwede magkaroon ng strip perforation. Nakakalungkot, diba? Pagkatapos mo paghirapan hanapin yung canal, linisin yung canal, tapos bigla na lang magkaroon ng strip perforation sa paglalagay ng post. So ito persistently symptomatic in tooth. So yan, nung root canal retreatment niyan, tinanggal yung post. And ultrasonics yung ginamit niya to remove the post. Tinatanggal niya dahan-dahan yung post. Nag-start nang gumalaw yung post within the canal. Ikot lang, ikot hanggat matanggal na yung post. Tapos, nakakita siya ng strip perforation sa loob. So, may iba't ibang cases pa niyan. This video, we will be sharing with you doon sa lectures na ibibigay sa inyo. Next, afternoon schedule. Sabi mo, kampante na ako ngayon. Tapos na-manage na yung mga furcation perforation at saka yung strip perforation. Pero may tumawag sa inyo biglang pasyente na masakit yung ipin niya. Anong model ng cellphone yan, Dok? Naalala niyo pa? Anong model yan, Dok?
Iba yung akin, Dok, eh. 3310 yung akin.
3310 din yung akin natin. Yan yung next na mas maliit, no, sa 3310. Hindi ko na maalala. Pero yan pa yung panahon. Ewan ko kung buhay na kayo noon. Yung panahon na bumibili ka pang
6600 po.
Ano pangalan niya? 3300.
6600.
Wow. May ganyan ka nun doon. Tsaka nun, di ba, Dok, parang joke lang yung sinasabi na next time, makikita mo na yung mga kausap mo sa phone. Parang, wow. Parang samantala ngayon, it's a reality already. So, sabi ko nga, yun talaga, no? Kung ano yung nakikita mong weakness ng present condition, you work around that, then you improve, no? Whatever conditions you have at the moment. So, for example, this patient calls you, sinasabi, Dok, sumasakit yung ipin ko, yung ginawa natin. Tapos pag-check mo, na-obturate na. Di ba? Parang nahanap mo lahat ng kanal, umabot ka hanggang dulo, solid naman yung obturation, and yet you see persistent infection. So kapag ganyan, sabihin niyo sa pasyente, you suggest yung apicoectomy. Kasi nahanap niyo na lahat ng kanal. Umabot kayo sa entire working length of the tooth. Ito yung pasyente na ilang beses na siya, siguro pang 4 akong pasyente na nag-retreat sa kanya. So sabi ko sa kanya, let's see kung mag-respond siya ng surgical root canal retreatment yung case mo. So nung una nag-work, tapos biglang, nung lockdown pa yan, ECQ pa no, na takot pa kami mag-reopen ulit ng clinic. Sabi niya, Dok, sumasakit yung na-obturate, yung na-root canal natin dati. Siyempre, pag take ko nun ng radiograph, sabi ko, nahanap ko naman lahat ng kanal. Solid naman yung obturation ko, and yet may persistence ng infection. So kapag ganyan, dahil wala ka namang i-retreat, tatanggalin, dahil intact pa rin yung restoration na nakalagay sa kanya at that time, sabi ko dun sa patient, the next step is for us to do an apical surgery. So, tinawag yung kaibigan ko, sabi niya, safe ba na mag-open na tayo ng, magtrabaho na tayo with patients? Sabi ko, magagawa ko? Sabi ko, sumasakit yung ipin ng pasyente. So, nag-apico kami, nagtanggal ng infected soft tissue, nag-resect, naglagay ng MTA at the tip, and then, ito, a few months after apicoectomy, makikita niyo yung difference, no? Na ito, yan yung persistent infection. After apicoectomy, nagkaroon ng complete bone filling sa lahat ng area na dati radiolucent. So tuwan-tuwa kami, tuwan-tuwa din yung pasyente. At itong pasyente na to, tuwing dadating, meron siyang siguro at least 3 toys, no, para kay Ana. Kaya punong-puno na yung toy box ni Ana ng toys dahil dito sa patient na to. Sobra siyang love. So when we do apical surgeries, kailangan nagre-retro-prepare. This area is retro-prepared using endodontic ultrasonic tips, surgical endodontic ultrasonic tips, kaya siya nakahook para kahit harap yung pasyente, mare-retro-prepare yung region na yan. And this area that was retro-prepared will be sealed using mineral trioxide aggregate cement. Siyempre noon, amalgam ginagamit or zinc oxide eugenol, super EBA or GIC. But nowadays, for apicoectomies, ang ginagamit na rin ay mineral trioxide aggregate cement. This produces a good seal at the apical area kahit maraming bleeding dyan. It's a hydrophilic material, so it was still set in the presence of all the blood surrounding it. It's a biocompatible material that induces healing. So ito yung Dovgan carrier, kagaya nung nasa video kanina, pero sabi ko nga, hindi available itong Dovgan carriers na to dito sa atin. Ito yung available sa atin, MTA carrier. Meron akong small at saka medium na MTA carrier. I use both MTA carriers. Depende kung saang area nandoon yung perforation site or kung saan ko gustong dalhin yung MTA. The small one, I use to place MTA inside the canals o kaya dun kapag nag-apicoectomy. But the medium MTA carrier I use for furcation perforation repair. So kung may persistent na infection, MTA was used as a retrofilling material dito sa area na to. There are other clinical applications of mineral trioxide aggregate cement. Hindi lang siya kapag may furcation perforation, strip perforation, or for apicoectomy. It's now also being used as a material for direct pulp capping. So when you have a healthy pulp that was exposed during caries excavation, in the past, we've been taught to use DICAL, yung calcium hydroxide, or glass ionomer liners yung ginagamit noon. But nowadays, ang dami-daming studies supporting the use of MTA for direct pulp capping of healthy pulp tissue. Ibig sabihin, walang any sign or symptom ng irreversible pulpitis. Parang itong patient na to, no, nagka-caries excavation ako, nagtanong ako kung may history of pain. Maya-maya, nakita ko, uy, sabi ko, merong pinpoint bleeding. So I asked the patient, sumakit na ba yung ipin na yan dati? Sabi niya, Dok, wala, never sumakit yung ipin na yan. Sabi ko, pag kumakain, mainit, malamig, umiinom, sumasakit ba, nangingilo ba yung ipin na yan? Sabi ko, hindi. So this is a healthy pulp that was exposed dahil nga gusto natin noon, sobrang puting-puti lahat ng area. So we want to preserve the vitality of the pulp within the tooth. So we can use mineral trioxide aggregate cement for direct pulp capping. This promotes, MTA once placed over there, promotes dentin bridge formation adjacent to that pulp tissue. So MTA can now be used for direct pulp capping. And for this patient, I use the MTA SEM by Nexobio. Mabilis yung setting nito. Kaya gusto ko siyang ginagamit for direct pulp capping. So pagkalagay ko ng MTA, kumukuha lang ako ng cotton pellet. Kaya shining yung area na yan. I place a moist cotton pellet over it while I'm waiting for it to set. So this material sets, this brand of MTA sets in 15 minutes. So pagka-set niya in 15 minutes, nag-proceed na ako with restoration. Ngayon ay nasa 5th year recall kami ng patient na yan. Hanggang ngayon, asymptomatic yung ipin. Next patient. Meron siyang carious lesion, exposing the pulp horn region, pag-take ng radiograph, open apex pa itong tooth na to. So, nag-decide yung clinician managing this case na magtanggal ng superficial pulp that's closest to the carious exposure. So, in the past, we've been taught to use formocresol, glutaraldehyde, or calcium hydroxide for such cases. Kapag nagpupulpotomy dati, yun yung mga ginagamit, formocresol, glutaraldehyde. This we place onto pulps with minimally inflamed pulps with immature apices. So pag open pa yung apex, tapos minimally inflamed, ibig sabihin lang ng mami, sumakit lang yung ipin na yan. Isang beses, tatanungin nyo, tuwing kailan sumasakit? Ay, pag napapasakan lang ng pagkain. So you know that the pulp is minimally inflamed. The next question you always need to ask is that, was there an episode of pain such that the patient couldn't sleep at night? Na in pain siya all throughout the evening. So kapag in pain yung pasyente all throughout the evening, hindi minimally inflamed yung pulp. Pag sinabi ng mami na, hindi Dok, pag kumakain lang, pag napapasakan ng food, tsaka lang sumasakit yung ipin, tapos nawawala naman. Then you can try pulpotomy because this will preserve the vitality of the pulp in the radicular portion. So in pulpotomy, we remove the pulp in the chamber and then that area will be sealed with mineral trioxide aggregate cement and the dentinogenesis can continue so that the root formation will be completed. So months after, sometimes after a year, nagkakaroon ng completion ng root formation. So kagaya nitong patient na to. So itong patient na to, nagpe-prepare naman for orthodontic treatment. So pag-examine ko ng teeth, merong isa that needed a restoration. Pag-excavate ko, sabi ko, ay, lumabas yung aming pulp tissue. Tinanong ko, sumakit na to dati. Sinabihan ako na minsan lang pag kumakain. Pag hindi kumakain, hindi masakit. I check, open apex pa, because this is a candidate for pulpotomy. So I remove, under local anesthesia, I remove the pulp in the chamber, control the bleeding at the orifices, na-control naman yung bleeding. And then, ginawa kong parang base na niya, yung MTA. I placed mineral trioxide aggregate cement in the pulp chamber region and then sealed that area with glass ionomer and a composite restoration. So, ting babalik yung pasyente for orthodontic adjustment. Tanong ako ng tanong. Sabi ko, sumakit na ba yung ipin na yan? Sumakit na yung ipin na yan? Tapos sabi niya sa akin, Dok, palagi mo akong tinatanong kung sumakit na ipin na yan. So, gusto ko kasing ma-monitor yung ipin mo. So sabi niya sa akin, bakit Dok? Dapat ba sasakit? Sabi ko sa sarili ko, syempre hindi. So dahan-dahan ko sinabi sa kanya, hindi dapat sasakit yan. Pero gusto ko lang ma-monitor, kaya kita tinatanong. So next use of mineral trioxide aggregate cement is that we can also use it onto teeth with necrotic pulps, pero open pa yung apex. So for such teeth, hindi na magko-continue yung root formation using pagka in-extirpate natin yung pulp kasi wala na, necrotic na yung pulp. Pero we can use MTA, place MTA in that area of the tooth, in pulpless teeth with open apices. Pero ito yung pulpless teeth due to pulp necrosis. So tatanggalin mo na lahat ng necrotic, non-vital pulp tissue within the tooth and then replace it with MTA. So ito yung tinatawag nilang apical barrier technique kasi open apex pa. Pero nung wala pang MTA in the market, we used to use calcium hydroxide. So yung calcium hydroxide is placed, alam natin to no, sa lectures, we use calcium hydroxide as intracanal medicament. But for these cases, yung open apex, teeth with open apices, we place calcium hydroxide every 3 months hanggang mag-continue root formation, hanggang magkaroon ng apical closure. Ang problema with that procedure, ang tagal bumabalik-balik ng pasyente. So yung unang 3 months, pangalawa, pangatlo, bumabalik yan. Pang-apat, medyo late na, papare-reschedule. Panlima, halos ayaw nang bumalik. Nagkaka-burnout na yung pasyente habang nagkakaroon ng continued root formation. So para maiwasan yan, yung patient burnout, sinasuggest nila is for us to place MTA for apexification. Ibig sabihin, after canal instrumentation and cleaning of the canals, we place MTA dun sa last 5 millimeters of the canal. Kaya tawag nila single visit apexification. So we place MTA at the last 5 millimeters of the canal to achieve the seal at the apical portion. Then once it has set, we can place the root canal sealer and the rest of the canal walls and then place your gutta percha. So inisip na iba, bakit hindi na lang MTA all throughout the canal space? Napakahirap tanggalin ng MTA kung hindi mag-respond favorably yung pasyente. Kaya ang suggestion ay MTA yung last 5 millimeters of the canal and then the rest of the canal, gutta percha and a root canal sealer pa din yung ilalagay. So ito yung isang patient na ni-refer for apexification using MTA. Sa buong buhay ko, ito yung pinakamadali na gutta percha removal. Nung dumating itong patient, meron siyang provisional crown and a post. Pagtanggal ko ng provisional crown, sabi ko nga, ito yung pinakamadali, alalang-alala ko, pinakamadaling gutta percha removal sa buong buhay ko. Kasi pinulot ko lang yung nag-iisang nakalutang na gutta percha within the canal space. So pagtanggal ko ng kanyang suspended, freely moving na gutta percha sa loob ng kanal, wala ng cement. So inisip ko baka natunaw yung cement na nilagay noon ng dentist niya. After removal, naglagay ako ng, nag-irrigate. Siyempre, hindi na ako masyado nag-instrument ng canal walls. Ano pa bang pagpapalaki ng canal walls ang gusto ko? Malaking-malaki na yung canal walls. So, nag-instrument lightly, tapos nag-irrigate abundantly, tapos naglagay ako ng calcium hydroxide. I placed calcium hydroxide muna kasi MTA sets in the presence of blood. MTA sets in the presence of an exudate, but it will not set in the presence of pus. So, dahil nga matagal na natunaw yung cement, meron tayong periapical radiolucency. So sabi ko dun sa parent, kailangan ko muna maglagay ng gamot to control the infection within the tooth. And then after placing calcium hydroxide, pagbalik ng patient, naglalagay na ako ng MTA. Dapat pinupush ko yung MTA papunta sa apical portion. Nag-set yung ginamit ko MTA, ng ganyan pa lang. Sabi ko, Sabi ko, I have a problem. So kinausap ko yung mami. Sabi ko, mami, ideally, sabi ko, yung MTA na nilagay natin, yung cement na nilalagay natin should reach the end of the tooth. Pero, sabi ko, pag pinupush ko, ganyan lang siya. So, ang suspecha ko, baka resorb yung isang wall, kaya hindi na rin nag-push past the apex, or nag-set prematurely yung MTA na nilalagay natin. So dito ako sa case na to natuto na gumamit ng iba't ibang brands ng MTA kasi dito ginamit ko yung MTA that sets in 30 minutes. Then I realized that dahil nga mabagal yung pag-work ko, pag sinisigurado ko ma-reach yung dulo, magte-take akong periapical radiograph, sabi ko hindi pala dapat yung MTA that sets in 30 minutes yung ginagamit ko dito. I should have used a longer setting MTA. So sabi ko dun sa mami, ganito po, this area is clean now. Wala nga lang filling material. Let's see, sabi ko, kasi sealed naman hanggang dito sa portion na to and the rest of the canal space, I will seal using a root canal sealer and a thermosoftened gutta percha. Then we'll take recall radiographs. Sabi niya, Doc, malayo kami. Pwede ba yung dentist na lang namin yung mag-take ng x-ray, papadala sa inyo? So sabi ko, or sige, tapos balitaan niyo po. Sabi ko sa kanya, ito, pwedeng ganyan lang siya. Kung symptomatic, ire-resect ito hanggang sa area na may MTA. So pumayag naman yung parent. So ito yung itsura ng obturated tooth. Ito yung thermosoftened gutta percha, MTA, itong tip, hollow itong apical portion. Sabi ko dun sa referring dentist, hindi kailangan niya lagyan ng poste kasi sufficient itong coronal portion to hold a crown. So, syempre, tuwan-tuwa din yung mami, hindi kailangan maglagay ng poste. And then, pagka nakikita ko yung referring dentist, na nakita ko na minsan yung referring dentist, sabi niya sa akin, Doc, sabi niya, the tooth has healed very well. Asymptomatic na yung case. Sabi niya, hindi na lang po nakakabalik yung patient sa inyo, pero sabi niya, the tooth has healed well. Sabi ko, that's good news, sabi ko. Pero syempre, gusto ko pa rin yung recall radiograph sana. Next. This patient was referred for the management of root resorption. So, una tinatry i-access ng associate dentist ng kaibigan kong dentist, sabi niya. Tapos sabi niya naliligaw ng landas na ng mid-access radiograph. Sabi ko, tumisi na. Sabi niya, re-refer na lang namin kasi may root resorption na ganyan na tatakot silang i-manage. So I started explaining to the patient the need for mineral trioxide aggregate cement for sealing that area kasi wide yung area nung sa apical portion of the tooth. So dito, natuto na ako. Di ba? Sabi ko sa inyo na natututo naman ako dun sa mistakes of the past. So kailangan, for this case, alam ko na I should use a longer setting MTA. Hindi ako pwede nung mabilis na nagsiset na MTA. So I used Angelus MTA for this case. Nakita nyo, natuto naman ako, di ba? Ayan na, approaching the apical portion, hanggang dyan lang may canal. So, hanggang dyan, na-push ko na yung MTA dito sa apical portion. The rest of the canal space, nilagyan ko ulit na root canal sealer, a resin root canal sealer. Tapos nilagyan ko ng thermosoftened gutta percha. Tapos binalik ko na siya doon sa referring dentist. So, tinanong nila ako, kailangan ba i-crown? Sabi, hindi po. Sabi ko, composite restoration, direct composite restoration. Pwede na for that case. So kapag kami irregularities na ganyan, gusto ko MTA yung ginagamit kasi nagko-conform siya dun sa irregularities. Now let's summarize the different clinical applications of mineral trioxide aggregate cement. We can use MTA for direct pulp capping of exposed healthy pulp tissue. So again, pwede lang mag-direct pulp capping. MTA would work for direct pulp capping if we have a healthy pulp tissue. Kaya nga, it's very important that we learn to delineate when a pulp is healthy, when it's starting to go through the disease process, and when it is necrotic, so that we can use the materials appropriately. Hindi lahat ng pulp exposures ay exposures ng healthy na pulp tissue. You get the history para malaman ninyo mabuti, no? Kung pwede na kayo sa direct pulp capping with MTA, or kung minimally inflamed yung pulp, then you can do pulpotomy. Remove the pulp tissue in the chamber or the most superficial part of the pulp chamber region, and then you can place MTA over it. We can also use MTA for apexification. When we have a necrotic pulp on a tooth with open apex, then we can place MTA dyan sa area na may open apex to seal that area. We can also use MTA for the management of root resorption because it will conform to the irregularities within the tooth. We can also use MTA for furcation perforation repair. Sabi ko nga, wag lang maging denial kapag parang may perforation. So verify if you have a perforation. So you can manage the case appropriately at the soonest possible time. If you have a strip perforation, you can also use MTA to seal that area doon sa na-expose na periodontal ligament tissues dito sa inner wall of the tooth. We can also make use of MTA as a root end filling when we need to do apicoectomies. So ito yung summary ng iba't ibang clinical applications of mineral trioxide aggregate cement. So I call the practice a stress-free endodontic practice. If we have MTA in the clinic, because if any of these cases would arrive in the clinic, then I have the appropriate means to manage such case. I've mentioned earlier that we use different brands of MTA kasi kung gagamitin ko for furcation perforation repair, gusto ko yung MTA that sets fast. Yung in 10 minutes set na yung MTA. For direct pulp capping, gusto ko din yung fast setting na MTA. But if ganun din sa pulpotomy, fast setting MTA din yung gusto ko. But if I want to use it for root resorption repair or apexification, kasi ang tagal din ng time na pag pinupush yung MTA sa apex, I prefer to use the longer setting MTAs. Kaya dapat sine-check ninyo yung manufacturer's instruction. Gaano katagal bago magsiset ang bawat particular brand of MTA para hindi nyo na maulit yung mistake ko dati na gumamit ako ng fast setting MTA na kailangan kong i-push apically yung MTA for that particular patient. At this point, do you have any questions? For the different applications of MTA? Wala?
Hi, Doc.
Yes, sir.
Doc, may naririnig po ako sa other colleagues ko na nagpa-practice ng endo na ginagamit nila all throughout from the apex up to the orifice.
Opo.
Buong
Siya yung
MTA.
obturating material na nilalagay nila.
Acceptable po ba yun, Doc?
May isang school of thought na yun yung itinuturo nila. Pero ang experience ko kasi, Doc, napakahirap pagka root canal retreatment pag kailangan tanggalin yung MTA all throughout the root canal space. Meron po kasing isang na-refer na patient sa akin na ganun yung ginawa ng dentist niya dati. Tapos nung sumakit, naging symptomatic, ayaw naman niya ipabunot yung ipin niya, kinailangan kong tanggalin yung MTA na nilagay sa lahat ng canals. So yung ganyan kong kahaba na endodontic ultrasonic tip, nung natapos kong gamitin na pantastas ng MTA, kalahati na lang siya, Doc. Nangalahati yung diamond coated ko na endodontic ultrasonic tip when I had to remove MTA. So ang sakit sa ulo kasi syempre, ang mahal at that time, mahal pa po yung endodontic ultrasonic tip. Parang yung bili ko 9,500 isang tip. Tapos nangalahati siya. Tapos yung chair time na na-consume ng pagtastas ko ng MTA, napaka-tagal na time din. So kapag ka ganon, syempre kailangan kong i-charge yung pasyente appropriately. Tinatanong ako ng pasyente, bakit po ang mahal? Sabi ko, kasi kinailangan kong tastasin yung old material, old cement na nilagay sa inyo, and it's not the ordinary root canal cement that's usually being used. So yun lang, Doc, yung aking comment dun sa mga gumagamit ng MTA from the orifice down to the apical portion. Na pag root canal retreatment na ng mga cases na ginawa nila, kung ako personally, mas gusto kong pabalikin na lang sa kanila yung pasyente. Parang kayo magtastas niyan kasi napakahirap. One, napakahirap. Pangalawa, napakamahal ng materials na gagamitin ko pantastas ng MTA na yun. Kung hindi, papabunot na ng pasyente yung case. So, di ba sabi natin nun sa obturation lecture, pag pumipili tayo ng obturation material, kailangan retreatable pa rin yung tooth. So, retreatable na hindi naman ubos yung oras mo. Tingin ko, Doc, very good siya na way, na pang seal. Pero, ang problema, paano kung kailangan ng retreatment? Kaya hindi po ako nag-MTA all throughout the tooth. Hanggat maaari, kung hanggang saan lang yung perforation site, kung strip perforation man yun, or kung i-MTA ko all throughout the tooth, sinasabi ko dun sa pasyente, in case you would need root canal retreatment na tatastasin yan, it would be very difficult na baka papabunot niya na yung ipin pagka mag-fail. So, yun lang yung tingin ko, Dok. Kasi nga, ako naka-experience ako ng hirap ng pagtastas.
Thanks po, Doc.
You're welcome.
Bakit mo pala ni-retreat yun, Doc, yung MTA-treated food?
Sumakit, Dok. Sumakit na masakit. Tapos nung chinek ko, sabi ko, bakit ganito ka-opaque? So, nung binuksan ko, tinanggal ko yung tinanggal ni Doc Malo yung crown, tinanggal ko yung restoration on top. Pagtingin ko, sabi ko, puti na cement. MTA siya talaga all throughout. So, ni-retreat ko. Tapos, sabi ko na lang dun sa patient, sabi ko, pasensya na matagal po. Parang, kami Doc, isang kana, multi-rooted 3 kana, lower molar yung ginawa ko. Sabi ko, ma'am, pasensya na ha, sabi ko, kasi isang kanal lang, ubos na yung energy ko. Kasi halos 2 hours kami magsugsog ng MTA sa bawat isang kanal. So, parang 3 sessions kami initially, pagtanggal pa lang ng MTA doon sa loob ng kanal. Tapos yun nga, naawa ako, Doc, nung nakita ko yung ultrasonic tip ko. Kalahati na lang. Doon yata ako, Doc, mas na-affect ko. nung nakita ko hirap-hirap yung ultrasonic tip ko.
Nag-fail din pala yung MTA, no, Doc?
Ano yun, Doc?
Nag-fail din pala yung MTA. Nag-fail din.
Nag-fail, Doc, kasi, di ba, kahit maayos na maayos yung pagkaka-root canal natin, kung bumagsak yung immune system ng pasyente, talo pa din. Kaya nga, Doc, kapag nag-endo tayo, ang ginagawa natin, eliminate natin yung sources of infection. Pero, hindi natin masabi yung response ng pasyente. Majority of the patients would respond favorably. Pero merong a few cases na mag-fail kahit maayos yung pagkakagawa. Doc, yung mga cancer patients ko na ongoing yung chemoradiotherapy nila, bihira sa kanila yung successful yung management. So, kapag ganun matagal, habang kinikimo sila, kina-calcium hydroxide ko muna sila, tapos nagba-blood test pa po kami bago kami mag-obturate. Kasi kung bagsak yung WBC niya, kasi wala siya masyadong defense cells, hindi ako nag-obturate, Doc. Kasi alam kong hindi magsasucceed, yung usually nagsasucceed na management para sa isang healthy na pasyente kasi immunocompromised sila sa state nila. So may nag-fail din, Doc. Wala pang perfect na obturation material. Wala pang dental material na sana pag inilagay natin, may mare-revive na kaagad yung pulpal health or yung vitality of the pulp. Wala pa. Hanggang ngayon, baka kayo, Doc, makaka-discover. Pa-share naman po.
Thank you po.
Kaya tayo, Doc, aral ng aral, update ng update. Kasi yung mga researches geared towards the development of the weaknesses of the present materials that we have. Yan. Next question. Ano po ang pinantatanggal nyo sa coronal pulp during pulpotomy? Kung malaki yung area, sabihin it's a molar, meron ako yung sharp na endodontic spoon excavators, pwede yun. Or yung iba gumagamit ng round burrs. Hindi ako fan ng paggamit ng round burr sa pagtanggal ng pulp tissue sa coronal portion. So ako mas sharp na endodontic spoon excavator yung ginagamit kong pantanggal ng coronal pulp tissue. At paano po, Doc, ang effective na pampatigil ng bleeding pagkatanggal ng coronal pulp tissue? Gumagamit lang ako, Doc, ng cotton pellet with a little bit of sodium hypochlorite doon sa canal walls. Tapos nakokontrol yung bleeding. Pagka nakokontrol yung bleeding, Doc, ibig sabihin minimally inflamed yung pulp. Natanggal or na-scoop out nyo na yung oozing na pulp tissue. Ibig sabihin, yun yung irreversibly damaged na pulp. Pagka yung pulp na natira ay hindi ninyo makontrol yung bleeding, ibig sabihin, irreversibly inflamed yung pulp tissue na yon. Ibig sabihin, hindi siya candidate for pulpotomy. I-discuss ni Doc Maloy ang pulpotomy on Wednesday, yung vital pulp cap. Wait po, may send po akong photo. Sige, Doc G, titingnan ko yan. At Doc, mas better ba na po yung MTA for pulp capping compared to light cured calcium hydroxide? Ako, Doc, mas gusto ko po yung MTA for direct pulp capping kasi mas marami siyang studies. Siyempre, matagal na rin ginagamit yung calcium hydroxide as for direct pulp capping na material. Pero dahil inherent sa calcium hydroxide yung solubility, after several years, may calcium hydroxide ka nilagay na for direct pulp capping, tapos may restoration on top. So, after several years, na matunaw na yung calcium hydroxide liner na nilagay mo, restoration nandun pa din. Pagkagat ng pasyente, dahil hollow na yung ilalim, pwede mag-break yung restoration. Pag nag-break yung restoration, lahat na ng bacteria ng saliva papasok na through the broken area. Tapos ma-affect na niya yung dentinal tubules, papasok sa pulp tissue. So ako, Doc, mas gusto kong nag-MTA for direct pulp capping. Hindi po ma-dissolve ng hypochlorite yung pulp. Kasi, Doc, mabilis lang. Kaya hindi na di-dissolve ng sodium hypochlorite yung pulp tissue. Ano lang, Doc, parang dadaanan mo lang na mabilis. Di ba? You need about 40 minutes ng contact time ng sodium hypochlorite at pulp tissue para ma-dissolve ng sodium hypochlorite yung pulp tissue. So kung mabilis lang, napanlinis mo lang ng walls, tapos tatanggalin mo na yung excess na sodium hypochlorite, hindi ma-dissolve yung pulp tissue. Question, Doc, resorb po ba yung root ng 2.5 due to impacted 2.3? Ay, paano ko yan makikita, Doc? Pag kinlik ko to, makikita ko yan. Let me see. Click again to open. Ayan. Resorb po ba yung root ng premolar? Dahil dito sa, ano to, Doc? Pagka ganitong case, pwede kasi naka-superimpose. May natatanaw pa rin akong root outline sa likod eh. Best po nito para sa ganitong case, request po kayo ng cone beam CT scan para makita nyo in 3 dimensions. Baka mamaya naka-superimpose lang, hindi naman pala resorb. So you have to check po with the cone beam CT scan itong photo na to. Doc G pa, sabihan niyo po yung patient, kailangan niya magpa-CT scan para makita niyo in 3 dimensions yung posisyon ng impacted na canine at saka yung tooth number 25. Any more questions? Wala na ang question. Meron pa isa. Thank you daw, sabi ni Dr. Okay. So kung wala nang questions, let's proceed with the lecture on single versus multiple visit root canal treatment. Dok, nagsi-single visit RCT kayo?
Hindi, Doc.
Hindi. Bakit, Dok? Ayaw nyo lang?
Hindi ko pa na-try.
Sige. Bali, parang gano'n naman yung ginagawa natin sa workshop. Yes, ang sagot ni Doc. Okay. So yung multiple visit root canal treatment, yan yung either 2, 3, 4, 5, several sessions ninyo nakikita yung patient during treatment. So when we do multiple visit root canal treatment, this allows clinicians to enhance root canal disinfection, lalo na yung mga nag-hand file. Kasi mahirap naman matapos in a single visit. At sabi ng mga studies, with the presently available regimens, yung ng infected root canals, about 1/3 remain infected after one treatment. So kapag infected yung pulp canal space, yun yung recommendation nila, mag-multi-visit root canal treatment. We also recommend multiple visit root canal treatment for patients with temporomandibular joint disorder. This increases the patient comfort during treatment because they don't have to open their mouths too long during the dental appointment kung multiple visit root canal treatment yung gagawin. This also allows clinicians to observe the progress of healing. So dati namamaga yung pasyente nyo, kamukha siyang Jollibee nung nag-start kayong mag-treat. Tapos yung susunod naman, makikita nyo dahan-dahan lumiliit na yung swelling, tapos hanggang sa ma-flatten na yung swelling. Kaya na-observe mo yung progress of healing sa multiple visit root canal treatment. Yung single visit root canal treatment naman, that's when you diagnose, you perform your access cavity preparation, you finish your instrumentation, and you obturate also during the same visit. Siyempre maganda rin if you can restore during that appointment, pero baka naman mamaya, lockjaw na yung kapalit nun. Sa sobrang tagal na naka-open yung bibig ng inyong patient. Some of the advantages of a single visit root canal treatment includes the clinician's awareness of the root canal anatomy immediately following instrumentation. We also do not risk losing important landmarks. No? Hindi na-chip yung cusp tip na ginawa yung reference point during the working length determination. So, kapag ganyan, alalang-alala nyo kung ano yung mga working length na ginawa ninyong reference points for working length determination. Ako hindi ako nakakatanda ng working length. Kailangan palagi kong nililista ano yung ginamit ko reference point, ano yung ginamit ko para sa pasyente, paano ko itinasok yung file na yun. I have to remember all those things. And they say the canal is never cleaner than immediately after proper instrumentation. And if we finish root canal treatment in a single visit, we don't have any risk of follow, flare-up, induced by microleakage or the breakage of the seal of the provisional restoration in between visits. And the teeth are ready much sooner for the final restoration. We decrease the likelihood of a fractured tooth when we do a single visit root canal treatment. Yung patient's pre-appointment anxiety and post-operative discomfort is also limited to one episode when we do a single visit RCT. And at the same time is also saved for the patient and the clinician. So kapag ka malayo, yung mga patients nyo nagka-travel ng 12 hours or longer just to see you in the clinic, syempre, kapag ka ganyan, gusto na rin natin na ma-decrease yung travel time nila papunta sa atin. Pero hindi lahat ng cases na gusto natin single visit RCT qualified for a single visit root canal treatment when we are unable to dry. When we are unable to dry the root canals completely, dami nyo nang nagamit na paper point. Gustong-gusto nyo pa yan, yung mga payat na paper points, O2 tapered. Pagka hindi nyo madry yung mga canals very well, then we cannot obturate during that visit. Probably there are still a number of bacteria inside the root canal space, hence the presence of the exudate. When there's also insufficient time to complete the procedure, padating na yung next patient, or sumingit lang siya sa schedule nyo, naawa kayo, nag-extirpate kayo ng pot, nag-instrument, sinisip niyo, obturate ko na ba ngayon? Sobrang stressful kung too close dun sa appointment ng next patient ninyo. Siyempre, kailangan din naman natin huminga, magpahinga sandali, no, in between patients. Hanggat maaari ako, ayoko nung sobrang siksik lahat ng schedule. Kasi gusto ko yung nakakahinga ako. Hindi ako haggard tingnan pagdating ng next na patient. Kailangan makikita niya, I am ready to see the next patient at hindi patong-patong sila lahat ng schedule. When we also see patients with possible increased stress on the temporomandibular joint, yung mga very limited yung mouth opening, then we don't do a single visit root canal treatment for these patients. For patients with increased psychological stress, because the treatment is taking a long treatment time, we have to shorten the periods of the appointment. So, when nagkaroon ako ng ganyang patient, ganun pala siya. Pag longer than 20 minutes na siya sa dental chair, bigla makikita mo, mag-iiba na yung itsura niya, kakapanik attack siya. Tinatanong niya ako, okay lang yung ipin ko, napapano na ako? Wala po, okay lang, hindi pa lang ako tapos maglagay ng mga gamot sa loob. Then I realized I cannot finish the dental appointment during, I cannot finish the procedure during that appointment kasi talaga nagpapanik siya. It's very important that we learn to do case selection for alin yung ipin na pwedeng single at alin ipin yung pwedeng multiple visit root canal treatment. When I was a dental student, we can only do single visit root canal treatment on teeth with vital pulps. Sabihin yung irreversible pulpitis or yung teeth na for intentional root canal treatment. So dahil healthy yung pulp na tatanggalin ko, walang periapical infection, pwede daw yung cases na yun for a single visit root canal treatment. And all the other conditions, kailangan multiple visit root canal treatment na yung recommendation. However, several studies much later on showed that there is no difference, statistical difference in the healing rate between a single visit and a multiple visit root canal treatment. Sabihin, mag-heal as well ang isang ipin na single versus multiple visit root canal treatment ginawa. There's also no difference in the effectiveness of the treatment, no root canal treatment. In terms of radiologic success, ibig sabihin kung dati may periapical radiolucency yung case, either nag-single visit or multiple visit root canal treatment ka, they will both heal as well. So nakita nila sa post-operative pain, flare-ups, and healing, wala ring difference kung mag-single or multiple visit root canal treatment tayo. Kaya binago na nila yung criteria. Pagpili, kailan magsisingle, kailan mag-multiple visit RCT. Yung single visit RCT nowadays is not just limited to vital pulp. Yung ipin na may pulp necrosis, na may apical periodontitis, or yung may chronic periradicular periodontitis, or chronic periradicular abscess, or condensing osteitis. Lahat yan ngayon pwede ng single visit RCT. So naiwan na lang for multiple visit root canal treatments when we do pulp necrosis, teeth with pulp necrosis na may acute symptoms, kasi in pain yung pasyente, namamaga sila nung dumating sa atin sa clinic, or yung mga patients na may acute periradicular abscess kasi gusto natin mag-subside yung swelling before we obturate. Yung endodontic retreatment naman, kung walang periapical radiolucency, nagsisingle visit RCT na rin kami sa kanila. Pero pag nakita namin may lucency, draining abscess, hindi yan talaga po pwede for a single visit RCT. We want the tooth asymptomatic before obturation. We want the tooth clear, no, of any exudate before we obturate the tooth. So let's look at some examples of cases na ginawa na single and multiple visit RCT. So this patient was referred for single visit RCT. Naturally, hindi ito, di ba? Hindi man ako nag-e-exo. Ayokong nag-e-exo ng mga pasyente. Kaya, definitely, hindi ito ang ni-refer sa akin. Sabi ko lang dun sa kaibigan ko, sabi ko, anong nire-refer mong patient? Sabi niya, Hans, Papa, RCT, pero very busy na businessman yung patient. So, ang request niya, single visit RCT. Sabi ko, let me see how I can help your patient. But I cannot promise a single visit RCT unless and until we have completely extirpated the pulp and instrumented the root canals. We have to check if the canals are dryable. So sabi ko, I will try my best to do a single visit RCT, but I cannot promise. And during the appointment, I will explain to the patient na din. But before I proceed with root canal treatment, please, sabi ko, take this out. Sabi ko, pag nag-build up ako ng missing wall, ayoko may nakaharang na ganyan. When you take it out, baka ma'am niya mabunggo pa to. So sabi niya, sige, sabi niya, papatanggal ko na yung third molar. So during the appointment, before we started, sabi ko dun sa patient, I will try to do, I know sir, you are requesting for a single visit RCT, but I will examine, sabi ko, in the middle of treatment, if the canals are dryable, after removing all the pulp tissue within the tooth and cleaning, then let's see. So sabi niya sa akin, okay. So naglagay lang ako ng GIC sa distal wall. Nakita niyo naman, may excess pa na GIC. Tapos nung the middle of treatment, chinek ko, dryable yung canal. So tinanong ko siya, sabi ko, would you want me to proceed? I will need about 40 minutes to obturate all these canals. To finish, I need about 40 minutes to finish everything. Or you want to see me on another day to finish the treatment. Sabi niya, kaya pa daw niyang umanga. So nag-fit kami ng master cone at nag-obturate during the same visit. So ito, nandito yung canal exit niya. Tapos balik na siya sa referring dentist. Hindi naman natapos kami ng single visit. So this is another patient, nakita niyo. Ay abscess. Pero dryable. Wala siyang swelling. Payat yung tooth. So nag-fit na rin kami ng master cone. Wedget yung ginamit ko and rubber dam sheets for isolating this tooth. So after canal instrumentation, irrigation, pag lagay ko ng paper point. After 2 paper points, dry na yung canal. Sabi ko, we can proceed with the filling in case you are ready. Tapos sabi niya, let's proceed and finish everything today. So nag-fit kami ng master ko at nag-obturate during that same visit. So this is another patient who was referred for a single visit RCT. So ito kala ko, isa lang yung canal niya, tanaw na tanaw hanggang apical portion. Pero pagkatapos mag-agitate ng sodium hypochlorite for a long period of time, nung mag-obturate kami, ay dalawa pala siya sa apical portion. Yun yung maganda if you agitate. Yung areas na inaccessible with the file, the sodium hypochlorite can dissolve the necrotic and vital pulp tissue in those areas. So isa pa din na to, nag-single visit RCT din kami for this case. 4 naman yung canals nito. So itong nag-obturate na. So this is another patient na ito naman sa Basilan pa siya nanggagaling. Nag-clean kami. Sabi niya, Dok, sumakit minsan yan. Sabi ko, talaga po. So pag-check ko, pag-touch ko ng Explorer dito, di ba? Sabi ko, wala pa access cavity preparation. Kumakaway na yung pulp tissue niya. So pag-touch pa lang niyan, sabi niya, masakit. Sabi ko, sige po, let's see. So nag-access kami, nag-instrument, tapos nung nalinis na yung kanyang kanal, nag-obturate na din kami during the same day. So hindi lahat ng pasyente ganun, pasimple na, straightforward, pwede mag-single visit root canal treatment. May mga patients, kagaya nito, nung tumating siya na in pain siya, pag old test ko, sabi ko, for endo na po itong upper second molar na to, pero sabi ko, very extensive din yung restorations ito, so kailangan bantayan. So after namin mag-canal instrumentation, sabi ko sa kanya, dahil po dumating kayo na in pain, I wouldn't want to obturate na asymptomatic yung tooth. For many patients, pagka irreversible pulpitis, ang suggestion nila, pwede nang i-obturate during the same visit. Pero ako, di ba, duwag ako mag-obturate kapag may history of pain yung ating patient. Question, hello Doc, sa microscope, anong nakikita mo ng kanal na alarm? Ano daw na yun, Doc? Nag-split sa apical portion, sa apical third ng kanal. Pagka tinignan ko sa microscope, Doc, ano yung natatanaw ko na kikita ko isa yung orifice, isa sa middle third. Pagka nag-zoom ako ng 25 times, nakakakita ko ng 2 orifices sa apical portion. So kapag ganun, alam ko, 2 yung kailangan kong linisin na canals. So kung naked eye, mahirap, no? Unless papasok yung file size 10 doon sa parehong canals. Minsan kasi malaki yung orifice in middle third, such that papasok yung 2 file size 10 doon sa 2 canals. Pag hindi, yun. Kaya, ganun, Doc, pagkatapos ng instrumentation, irrigation, tinititigan ko pa rin mabuti yung inner part of the canal just to check, no, kung meron pa akong makikita ng ibang entry points doon sa middle third ng canal.
Doc, as in para siyang tunnel na makikita mo talagang may 2 butas?
Yes, Doc.
Okay.
Pero nakikita ko lang siya pag naka-zoom ng 25 times.
Sinusunod na lang.
Pagka naka-zoom pa lang ako ng 15 and 10 times, 5 times, hindi ko siya nakikita doon. So pag nag-zoom kasi ng 25 times, tanaw na yung hanggang apical third ng kanal.
Okay. Thanks, Doc.
Pina-check din, Doc, sa iba't ibang angulation with the high definition mirrors.
Okay. Thank you, Doc.
You're welcome. Sa pang question, Doc, pwede after a month or months bumalik yung pasyente sa multiple visit RCT dahil sa location ng patient at minsan walang budget mga patient. Yes, Doc, pwede naman na a month or months after babalik, pero yung calcium hydroxide that we place inside the root canal space in between visits kapag nag-multiple visit root canal treatment tayo, nadidissolve siya naturally. Nagdi-disintegrate siya naturally after 3 months. So pagbalik ng pasyente after 3 months, makikita nyo hollow na ulit yung canal space. So kung babalik siya, malayo-layo yung interval, ganun, 3 months po do. Better syempre, best kung 1 to 2 weeks lang siya nakalagay. Pero if you need to place it for a longer period of time, okay lang. And make sure that your provisional restoration seals the coronal part efficiently. So kapag gano'n na matagal pa babalik yung pasyente, glass ionomer cement yung gamitin yung provisional restoration. Yung mga zinc oxide based na provisional restoration such as Fermin, Cavit, makakaseal siya pero hindi ganun katagal. Hindi aabot ng months yung adequate seal niya. Magkakaroon na ng marginal leakage. Next question, Doc. Pag nag-split po sa apical yung canal, need po bang 2 gutta percha on obturation? Yes, Doc. Yung unang gutta percha doon sa unang kanal na papasukan and then yung cut doon sa level kung saan nag-split yung dalawang canals. Tapos maglalagay na po ulit ng gutta percha papunta doon sa isa pang canal. And that second gutta percha seals even the middle and coronal third of the canal. Hindi po ako nagre-rely sa cement lang lahat yung nakalagay doon. Kung dalawang kanal siya talaga doon sa apical portion. So balik ako dito sa case na to, no, na describe natin. Dahil may episode of pain, nag-decide ako na mag-multiple visit RCT. So nung patapos na kami dyan sa tooth na yan, nalagay na ni Doc Malo yung composite onlay na final restoration ng tooth na yan. Nagparamdam na ang katabing molar. Sabi niya, ako din, Doc. So sabi ng patient, Doc, kailangan mo nang buksan yung katabi. Sabi ko, bakit? Sabi niya, kung ano yung naramdaman kong pain dati dun sa katabi, nawala for some time at naramdaman daw niya, ito rin. Hindi naman ako magtataka, very extensive restoration. Wala na halos pulp chamber. Halos faint na yung natatanaw na radiolucent lines para sa canal space. So ito yung ending. Tatlo sila. Tatlong bawat tooth. Obturated and restored na yan. You've seen this case. No? I think this case was shown by Doc Malol na yung patient namin na nagre-request na i-root canal yan, dalawang ipin na yan. Pero after performing vitality tests, itong second molar, ano lang siya, reversibly inflamed lang. Ang irreversibly inflamed is the third molar. Nag-instrument and then the following visit, dahil nga may history of pain, gusto namin makita mo ng pain-free itong pasyente na to. Pagka-fit ng master ko, nag-obturate na kami. So sana ganun lahat ng multiple visit cases. No? Yung first visit, access cavity preparation and canal instrumentation, sana lagi, no, pagbalik ng pasyente for obturation na. Pero hindi yun yung reality ng root canal treatment. May mga cases na makikita nyo ng 4 sessions, may cases na 3 sessions. Yung goal palagi, sana pag multiple visit, 2 sessions lang, tapos na. Question. Doc, ang fracture hindi nasiseal ng MTA. Masiseal niya, Doc. Pero, pagkakagat ulit yung pasyente, bubuka ulit yung fractured segments. So, ibig sabihin, masiseal niya up to a certain point doon sa fracture, pero pagkagat ulit ng pasyente, bubuka ulit yung fractured segments. So, open na naman for reinfection yung loob ng canal space. Kaya, hindi good yung seal, long-term seal ng MTA para sa fractured segments. Kasi pagkakagat ng pasyente, may wedging effect ulit yung kagat-biting force ng pasyente, bubuka ulit. Marire-infect lang ulit. So, hindi ginagamit na solution yung MTA sa pag-manage ng fractured teeth. So, punta naman tayo sa case na to. Ito naman, sinubukan ko na wag maglagay ng yung paper na cover dun sa phosphor plate nung nagtitake ng periapical radiograph. At ganun pala itsura niya. Matatanaw ko yung anino ng paralleling device. So, tinago ko tong radiograph na to kasi remembrance siya para sa akin. Na hindi pwedeng yung plastic cover lang nung paralleling, nung phosphor plate ang kailangan. Kailangan meron din ng black na paper or board around the phosphor plate para hindi nag-show yung shadow nitong ng paralleling device. So itong patient na to, pain din siya nung dumating dito sa clinic. Pag-check ko, sabi ko siya talaga yung ipin, source of pain. Ibang ipin, hindi. No? Normal siya sa pulp tests. Tapos itong upper molar na to, pag-check ko, sa mesiobuccal canal, hanggang dito, yung MB2 niya, hanggang dito lang. Ito yung palatal root at ito yung distobuccal root niya. So, yung susunod na visit na lang niya, tsaka kami nakapag-fit ng master cone at nakapag-obturate. Sa paton, in pain din yung pasyente. Siyempre naman, exposed na yung kanyang dentinal tubules. Kami, nag-canal instrumentation, irrigation during the first visit. Pagbalik niya, dryable na yung canals. So nakapag-obturate na kami. Kanyang 4 canals ng kanyang second appointment. Sana lahat, no, ganyan. So, ito naman, no, yung molar na yan yung gusto niyang patreat. Tapos sabi ko, kailangan pansinin din niya to. So, several sessions kami na naabutan kami lockdown, bawal muna lumabas siya, or ako naman yung not feeling well. So, very important na nag-agitate. Naglalagay tayo ng sodium hypochlorite, nag-agitate with, ito sonic device, si Eddie tip yung ginamit ko dito sa pag-agitate. So, dito, yung sodium, yung gutta-percha points, pinapakita lang na immersed. So I used pure strength sodium hypochlorite for 1 minute to disinfect the gutta-percha here. And then ini-air dry ko siya. Iniiwan ko lang sa ibabaw ng sterile na gauze. Mapapansin nyo, iba't ibang ways ako nag-bend ng gutta-percha points para meron akong palatandaan kung ito usually si mesiobuccal. This is the gutta-percha for the mesiobuccal canal. This may be used for MB2. Ito yung sa distobuccal canal at tapos sa palatal. Usually kinakat ko yung handle para nadi-differentiate ko yung mga immersed and disinfected gutta-percha sa obturation time. So ito na yun, nag-fit ako ng master cone. Take ng master cone fitting radiograph, tinry ko i-push apically yung mga master cone. Tapos nag-cement na kami during the same appointment. Kung mapapansin nyo, kala nyo ganyan kalinis yan agad. Hindi. No? Nagsistart din ako na madumi. Marami akong excess na root canal sealer around the canal walls during obturation. Pero tinatanggal ko ng alcohol. No? We use 70% ethyl or isopropyl alcohol with the microapplicator brush tip to clean the pulp chamber region. Tapos tsaka ko kinukunan ng photo. So ito yung MB1, MB2, DB, and the palatal canals. So yan ang mga cases for multiple visit root canal treatment. Do you have any more questions? The lecture, from the cases? Wala? O may naalala pa? Good evening po. Ask ko lang po kung paano nyo dinideliver sa patient kapag nakakita po kayo RCT ng ibang dentist na kailangan ulitin dahil short, etc. So kung short yung previous RCT niya, magpapalit ng jacket crown or kung ano man restorative work gagawin ninyo, tinatanong ko muna kung symptomatic. Pero kung magpapalit kayo ng extensive na restoration, bawa ng jacket crown sa ipin, sinasabi ko dun sa patient na it's best if we have a good recleaning of the inner part of the tooth before the final restoration is placed. It's up to you kasi sinasabi ko, the tooth may become symptomatic or the tooth may hurt anytime, pero mahirap naman kung kailan, sasakit siya kung kailan meron ng bagong final restoration. So kapag gano'n, may majority naman ng patients namin pumapayag magpa-retreatment before the final restoration is placed, before the new crown or bridge work is placed. Pero may mga pasyente din kami, Doc, na hindi pumapayag kasi sabihin nila, quiet naman for the longest time. So kapag gano'n, sinasabi ko, treatment option 1 is to repeat the root canal treatment kasi nakikita ko nga short na pwede nag-harbor ng bacteria yun sa loob. O kaya alam mo na, ang lapit-lapit na nung extensive na restoration sa pulp tissue na pag inulit ninyo yung restoration, alam mo pwede maging symptomatic yun too. So sasabihin namin sa pasyente, treatment option 1 is to retreat the root canal treatment, repeat root canal treatment before the final crown or bridge is placed. But the patient opts for treatment option 2, which is just to proceed with the changing of the crown or bridge work without redoing the root canal treatment. Tapos you have to make your patient sign that. Kasi minsan pagka-cement ng bagong PFM or bridge na ginawa ninyo, sasabihin ng pasyente, Doc, masakit yung ipin na kung saan tayo naglagay ng bagong crown. So kapag ganun, di ba, nakakainit ng ulo. Kasi alam mo, tatastasin mo yung trabaho. So kapag ganun, you have to explain very well. Ito yung ideal, pero ayaw niya ng ideal. Pero kapag pinili niya yung treatment option 2, na diretso sa pagpapalit ng crown and bridge work niya without redoing the root canal treatment, pagsasakit ulit, alam niya nagagastos siya ulit para sa disassembly ng crown at uulitin yung jacket crown niya na dapat ni-recommend na ninyong root canal na niya bago pag gumawa ng bagong crown or bridge work. Doc, if hindi afford ng patient ang MTA for pulpotomy, ano ang recommended medicament ninyo for pulpotomy? Hindi na doc recommended si formaldehyde. So, ang next best option yung pwedeng glutaraldehyde. Pero yun nga, mas mababa yung success rate ng studies doon kaysa kung MTA for pulpotomy. Pero doc, ang MTA ngayon hindi na sobrang expensive kagaya dati. Kasi dati doc, isang sachet ng MTA, yung sobrang nipis na sachet na feeling mo walang laman ng MTA yung sachet na yun, parang 4,000 pesos dati. Ngayon po may mga MTA na 2,000 pesos yung isang sachet na maliit. So that's enough, more than enough for pulpotomy. So kumbaga, kahit pa paano, bumaba naman yung presyo kasi ang dami-dami ng ibang brands na available. Mas mura po yung MTA na galing sa Korea. So yun yung pinakamura na MTA from Korea. Tapos yung mid-range ay yung mga galing Brazil. Tapos yung high-end, syempre yun yung mga unang inintroduce nun, yung ProRoot MTA. Siya pa rin yung pinakamahal at this point na presyo na MTA. You're welcome. Meron pa bang tanong for the lectures this evening? Doc, same MTA po itong powder at distilled water. Anong same, Doc? Yung pang pulpotomy? Yes, Doc. Yung MTA na sinasabi, diniscuss natin kanina, that's the MTA powder that we mix with distilled water. Minsan kasi di ba aalokin kayo, Doc, MTA, ano yan, root canal sealer yan. Yung MTA root canal sealer na binebenta nila sa market is a resin-based MTA na may MTA powder na kahalo. So pag pinagamit yun for obturation, you still need your gutta percha with that kind of MTA. Yung diniscuss natin for pulpotomy na MTA, for direct pulp capping, siya yung lahat ng pinakita nating applications sa MTA kanina, siya yung MTA powder that we mix with distilled water. Questions? Wala nang question? So kung wala nang question, pa-on ng inyong camera. Mag-roofing na tayo. At matutulog na maaga yung iba kasi workshop nila bukas. We'll see the last batch for the workshop tomorrow. Okay. Ready? 1, 2, smile. Isa pa, Doc. One more. Ready? 1. Doc Ina. Ready? 1, 2, smile. Isa pa, Doc. Okay. Yung mga mag-workshop bukas, huwag kalimutan picturean yung mga access cavity prep, pasend po ng inyong mga access, photos na access. So we see you tomorrow, those attending the workshop. And then on Wednesday, at 6:30 p.m., magle-lecture muna si Doc Maloy ng Vital Pulse Therapy. And then magsa-summarize ako ng lectures natin for the past sessions. Good night po.
Thank you, Doc.
You're welcome.
Bye, Doc. Thank you.
See you tomorrow.
Salamat po.
You're welcome po. I'll end the meeting for everyone.